Hello, I'm Julianna Amorese. I'm a senior nurse practitioner at the Johns Hopkins Pediatric Cardiac Intensive Care Unit, or PCICU. At the 8th World Congress of Pediatric Cardiology and Cardiac Surgery in Washington, D.C., I presented an abstract entitled Safe Early Initiation of Enteral Nutrition for Neonates in a Cardiac Intensive Care Unit. The abstract highlights the work that a multidisciplinary group of PCICU team members, including myself, has been doing regarding the implementation of feeding guidelines for neonates with complex congenital heart disease prior to a surgical or catheter-based intervention. It's important to highlight why our group created these guidelines and the outcomes we've been measuring. The clinical practice associated with providing nutrition to neonates with complex congenital heart disease is relatively unstandardized across heart centers nationally, despite accepted knowledge that providing enteral nutrition early is associated with improved outcomes. Difficulty is that these babies are at a high risk for poor systemic oxygen delivery and necrotizing enterocolitis, or NEC. Frequently, this results in the babies not being fed until an intervention is made to correct their cardiac anatomy and physiology. We sought to implement feeding guidelines to reduce the incidence of NEC, improve weight gain over the course of hospitalization, decrease the length of stay, and the number of infants requiring tube feeding at time of discharge. These objectives were determined by evaluating how our unit compared to other pediatric cardiac intensive care units who participate in the Pediatric Cardiac Critical Care Consortium database, or PC4. We retrospectively collected data for neonates cared for in our PCICU before and after feeding guidelines were incorporated into unit practice. We found the groups were similar in demographics as well as congenital heart lesions. We were able to demonstrate that implementing feeding guidelines for neonates with complex congenital heart disease did not result in an increased rate of NEC, although we saw no difference in the pre and post-implementation groups. We did, however, find that the hospital length of stay was decreased and the number of infants requiring tube feeding at time of discharge was lower and of statistical significance. So in conclusion, we were able to safely implement feeding guidelines for a high-risk population of infants with complex congenital heart disease. And thus far, the use of the guidelines has been associated with shorter hospitalization and an increased number of infants being orally fed at time of discharge compared to prior. Thank you.